So hello, everybody. As Bridget mentioned, I am Liz Herrick. I am with Maryland Medicaid in the Office of Innovation Research and Development. I am here to share a little bit about Maryland Medicaid's MOM program. We will not take more than 3 to 5 minutes of your time. It will be a quick presentation, as we know you're here for the webinar today. We have heard from the MAX team that many clinicians express concern over a lack of programs to refer patients to for help outside of their own settings. Medicaid operates a program specifically for pregnant and postpartum individuals who have opioid use disorder. We would love for your partnership in promoting and referring for this program. It's called MOM. Sorry, I'm going to go back and forth. So the MOM program funds our Medicaid managed care organizations to provide enhanced case management services to pregnant and postpartum Medicaid participants who have opioid use disorder. It is based broadly on 5 core case management pillars, as you can see here. Comprehensive case management, care coordination, that's helping participants make and keep their doctor's appointments, health promotion such as HIV and STI prevention and treatment, nutrition, family planning, etc. Individual and family supports, as in with participants' permission, identifying and involving who will serve as their support system throughout pregnancy, labor and delivery, and the postpartum period. And linkage to community supports, which is based on the participant's response to a social determination or social determinants of health screening. So what is different about MOM? MOM allows case managers to tailor their time based on the needs of the participant, rather than a set script. It starts with the social determinants of health screening, which informs a discussion of the individual's own goals. The idea is that, for example, the case manager doesn't just provide the participant with a WIC brochure, but they help them set up an appointment, ensure they have a way to get there. Same goes for doctor's appointments. The case manager aims to ensure the person makes and keeps their appointments, whatever that may look like for that person, be it transportation, childcare, etc. Participation is voluntary. There is no cost to the participant, and their Medicaid benefits are not affected if they don't choose to join. Really, this program is to support people who want to have a healthy pregnancy and a healthy baby while improving their overall well-being. This does not mean they need to stop using or that the program requires them to use MOUD, such as buprenorphine or methadone, though we do encourage it. MOM accepts participants no matter where they are in their journey. We believe that the program will still benefit individuals who continue to use, such as by having a plan to use safely, encouraging attendance at prenatal and postpartum care appointments, and accessing community-based resources, such as WIC and utilities assistance. We also welcome individuals who may not have used for years, as we know that pregnancy and postpartum can be challenging and pose risk for recurrence of use. As clinicians, you have the added benefit of seeing MOM care plans and social determinant screening as they are available in CRISP. Lastly, we know that this is a challenging population to engage. Identifying, referring, and enrolling individuals for MOM case management is all hands on deck activity. We need your help in this effort. As you can see here, we have a couple of links that would be available in the presentation that's shared. That will be the toolkits for media documents that are able to share, as well as a flyer. The flyer is available in English. Spanish translation is coming soon. Social media graphics in English and Spanish are coming soon as well. MOM referrals ultimately go through their MCO, but can be communicated to the local health department or even to us using the self-referral link that's available on the next slide, which is actually on this slide as well. So to wrap up, this slide contains our team's contact, as well as links to information for both consumers and providers. More importantly, this slide contains a link to our self-referral tool, both in the text and embedded in the graphic. We do have both an electronic toolkit as well as paper brochures available. Please do not hesitate to contact us if you would like access to these marketing materials or with any other questions about the program. And please fill out those prenatal risk assessments. Thank you so much to Max and for you for sharing their and your time with us this morning. Thank you so much. I'll hand it back to you, Bridget.
Thanks so much, Liz. Just to reiterate, if you did join late, I'll make sure that Liz's slides and contact information are included in our follow-up to you. That is a great service to take advantage of and also to help out by filling out those needs assessments. So please look out for all those informations, utilize those links, utilize those contacts. Right before we get started, I just want to reiterate that your microphone and camera are turned off. Today's webinar is being recorded. Please utilize the chats for any questions or comments. To ensure we get through today's educational content, we are going to go through the presentation and then have time at the end for questions. So once again, please enter those into the chat throughout today, and I'll be sure to relay them to Dr. Mark when it is time. Our last order of business before getting started is just an introduction of today's speaker. Today's speaker is Dr. Katie Mark, who is an obstetrician and gynecologist who holds dual board certifications in obstetrics and gynecology, as well as addiction medicine. Her research and clinical interests center around the intersection of reproductive health and substance use. She is the medical director of the University of Maryland Women's Health Center at Penn and the director of the Substance Use in Pregnancy and Parenting Outpatient Recovery and Treatment Practice. In addition to her obstetric practice, she has an ambulatory gynecology practice at the University of Maryland, where she cares for people with gynecologic needs throughout their lifespans. She performs gynecologic surgeries at the University of Maryland downtown and midtown campuses, as well as the Veterans Administration Hospital in Baltimore, Maryland. Dr. Mark is a great example of a consultant you would be connected with if you do call our warm line. So please keep that in mind. If you think of specific questions of patients that you treat in your practices and have questions, please call our warm line and we will connect you with Dr. Mark. I will turn it over to Dr. Mark whenever you are ready. I just made you presenter, so you should be able to share your slides.
Great. Everybody bear with me for a minute because it always takes me a minute to figure out how to share and then make it a presentation. So sorry that this is always more challenging than I think it will be. Okay, you can see my slides?
Yep.
Excellent. Okay, so thank you for that introduction. Hello, everyone. As Bridget said, we'll take questions at the end. So today we're going to talk about considerations in perinatal substance use treatment, patient education, and ethical issues. You've already been introduced to Max for Moms. Thank you for being here. Please use our services at will. I have no disclosures to make. Oh, this is a weird font. So the learning objectives today are to talk about the legal and ethical issues that create barriers in patients receiving optimal perinatal substance use treatment, review ways to mitigate legal and ethical issues in perinatal substance use treatment. My slides look different when I present them. This is very, I'm sorry, I just need to stop this for a second because it like changed all of my font. Let me see if I can do this in a different way. I'm gonna try to present, I'm sorry, everyone. I'm gonna try to present in a different way, but I don't think it would be sustainable to have to look at that strange font this whole time. Okay, I'm gonna do it web-based. Okay, this is better. Thank you for bearing with me. We're going to identify the need for patient and family education in perinatal substance use treatment and discuss patient and family education regarding overdose prevention. So when I started writing this talk, I had this like moment of existential crisis where I thought to myself, why do we even need to talk about ethical issues of taking care of patients when like this special population that's a very high needs and vulnerable population? Why do we even think that there are ethical problems surrounding this at all? And I think that when a person in society becomes pregnant, our brain sort of like societies are, like our society brain sort of splits and we have this cognitive dissonance. And the definition of cognitive dissonance is the state of having inconsistent thoughts, beliefs, or attitudes, especially as related to behavioral decisions and attitude changes. So for example, we say that maternal mortality is very high and we need to pay attention to that. But then we do not provide adequate health care to decrease maternal mortality. In fact, we have forced pregnancies and are taking away the rights of pregnant people in the name of babies. And so I think we get this sort of, we make it this dichotomy in our minds that it's like mom or baby instead of thinking about them together, and we sort of dehumanize and devalue the pregnant person. So I just want to recognize that society does this. I think that is ingrained in us, and our brains sort of naturally do that whether we want to or not. So to give this a little context and tell you maybe why your brain was programmed to think this way, I'm going to give you some historical context about how pregnancy has been criminalized, and we have really taken rights away from pregnant people. When they become pregnant, they no longer are able to make their own decisions. Oh, I'm sorry, I went the wrong direction. So back in, I think it was in the 50s, was the first time that there was a lawsuit about a birth injury that was referring to a birth that happened, an injury that happened prior to birth. So something that happened during labor, there was a hypoxic injury. And so that when this lawsuit came about, it was the baby that was suing for the injury. And again, suing for an injury that happened prior to birth. And when that happened, we sort of legally and societally started thinking about when do we start giving rights to a baby, and what rights does it have versus, and sort of naturally, unfortunately, we started thinking of those in comparison to babies' rights versus mom's rights. So then in 1973, Roe versus Wade made abortion legal. Of course, this has been overturned since that time, but it made abortion legal across the United States. And in the majority opinion, the Supreme Court Justice wrote, if suggestion of personhood is established, Roe's case, of course, collapses, for the fetus's right to life would then be guaranteed specifically by the 14th Amendment. So saying, if you say the fetus is a person, then never mind, abortion shouldn't be legal anymore. So then a week after that, the first human life amendment was proposed, and there have been hundreds of human life amendments since then, trying to distinguish this. When do we consider a fetus to be a human that has rights? So around that same time, in the 1970s, Richard Nixon was president, and he started waging his war on drugs. And he used very aggressive words in his discussion of his war on drugs, about how we were all soldiers in this war and we had to fight drug use. It was like an all-out affront against drug use. And this sort of very aggressive language weaponized society to feel that we were justified in judging or punishing people who use drugs, as opposed to thinking about like that as a medical problem. It was more, this is an enemy that we need to fight. So then all of this, thinking about, are babies humans, and when do they get rights, and then also this war on drugs was like the perfect melting pot for the crack baby, quote unquote, epidemic that happened. And so if you're not familiar with this, I could talk about it for 2 hours. I would implore you all to read about it. But there was this like media frenzy where they were talking about crack babies all the time, which of course what they meant were babies that were exposed to crack cocaine in utero, and how they were like this horrible burden on society. And it was this like really awful thing that happened. And they were this like underclass of citizens that we were not going to be able to take care of. And it was this awful thing. And it was really this huge drain on society. Well, it ended up that actually none of that medically was really true. It was all based on one very poorly designed study of 27 babies that was observational. And Ira Chasnoff was saying, like, I see this in babies that were exposed to cocaine. Really what he was actually seeing was the response to preterm birth. But it didn't matter. He's come out actually and said that he regrets it. He negates everything that he said in that 27-person cohort that he published, but it doesn't matter. You can't undo what has already been done, right? The blood is in the water. You can't take it out. And so this happens frequently. You've seen it, I'm sure, in, the political environment and other environments. You can say something that isn't true and everybody hears it. But as soon as you try to walk that back, then people aren't really paying attention as much anymore. And so there was no media frenzy to say, never mind, the crack baby epidemic wasn't a real thing. We were just kidding. It was too late. It was already ingrained in our minds. So this is an example of something that has created an implicit bias in our minds. So explicit bias is what you think of as like hate speech, discrimination, prejudice, like very purposeful things that people engage in. But implicit bias is more of your like gut reaction to something. And so most people have feelings and gut reactions to people who are pregnant and use drugs. And so that causes this enormous bias that even if people don't think that they have, again, this cognitive dissonance of like, I know that as a human being who deserves care and the same rights as everybody else in society, we're not actually acting that way, and our immediate response oftentimes is not to view them that way. And again, I'm not trying to make anybody feel bad by saying this. I'm saying we were sort of programmed to think this way. So you hear about this whole personhood and rights of the baby argument a lot in the abortion conversation that's going on. And it's hard to make the immediate jump to understand how that affects the way that we look at pregnant people who use drugs. But there's really a direct correlation, right? We're arguing about what are the baby's rights, and it's in your face all the time. We're hearing about this argument. And really what we're talking about is the rights of the fetus versus the rights of mom. Like, what right does the pregnant person have over her own body to make those decisions? And it's the same argument when we're talking about drug use, right? Like, are we going to punish her for things that she's done because it might have affected the baby? So I'm going to go through some different areas where we either are failing or could be doing better with relation to substance use and pregnancy. So talking about, I get questions about drug testing a lot, and who do you drug test? What do you do with drug testing? So the important thing to think of, I think I always want to take a step back whenever there becomes these questions that seem like a conundrum or cause this cognitive dissonance, and think like, what are we doing here? What is the purpose of what we're doing? And so this comes from a very good article that was published in the Green Journal in 2017. And they said, drug testing during pregnancy should result in the medical good, not merely the capture and stigmatization of those with a disease. The good should pertain to both the mother and the fetus. And so we're not doing it just so that we know that they use drugs. We're doing it because we want to have a medical benefit. We want to be able to provide some sort of resources and care. And that good really has to be for both the mother and the baby, because we are testing the mother. And if we are doing something to or on the mother that has absolutely no benefit to her, we really need to think about how we're making our choices. And then physicians should advocate for universal screening only as strongly as they advocate for social support and addiction care services for those subsequently identified. So I don't have these slides in this talk because there's a lot to go over, but if you look at the percentage of people that we're identifying with substance use in pregnancy over time, that's increasing. It's a very large amount. The care the services that we have to provide to those people are not increasing at that same amount. And so great, we're identifying it, but we're not at the same time advocating for care. So sorry, I'm really thirsty. Anyway, so again, always ask yourself, what is the medical benefit of this test to the patient? Why am I doing this? So in that same vein, thinking about timing of testing, there's a lot of hospitals across the country and in the state that do universal drug testing at the time of delivery. But I would argue that it's way too late at that point. Why are we doing it at the time of delivery? What is the benefit of that? Versus if you were to do it at the initial engagement of prenatal care. So this is testing and screening both if we're looking for substance use. If we're not doing it so that we can catch people in a lie, right? So that we can say, look, your drug test says that you were exposed to fentanyl and you told me you weren't. That's not what we're trying to do. What we're trying to do is provide a medical good. So the earlier in pregnancy that we test and screen, the more services we're able to provide to help that person have the healthiest pregnancy. Also, if you're going to be doing testing, understanding, we'll talk in a minute about the implication of testing, but actually understanding what the test is telling you. So first of all, a drug test is a snapshot in time, and every drug has a different amount of time that it'll be positive after somebody is exposed to it. And so urine drug tests, for example, overrepresent the amount of people that are using marijuana and probably underrepresent things like cocaine and fentanyl because they don't stay in the system for as long. But also, more importantly, there are a lot of things that can cause false positives. And frequently you need to get confirmatory testing, and that's frequently not done. So there was a study on providers that looked at how they evaluated urine drug tests, and only 30% answered more than half of the questions correctly. So basically, providers were very terrible at interpreting drug tests and understanding what they meant. So again, don't send a test if you don't have a purpose for it, or if you don't understand what the results really mean. So why am I focusing so much on drug testing? So one of the most common questions that I get asked is about reporting. And so this is one of the like ethical / legal biggest issues in the perinatal world. So you may or may not know, there are some mandated reporting laws. So the Federal Child Abuse and Prevention and Treatment Act, CAPTA, is this like federal mandate. And it basically what it says is that there needs to be a plan of safe care for substance exposed newborns. And they kind of let the states determine exactly what that means. But what Maryland has decided that means is in family law 5-704, whatever that is. And it's our response to CAPTA, and it defines substance exposed newborns and who needs to be reported to child welfare. So within this law, it's they state, and these words are coming directly from the law, this is not an interpretation. It says a healthcare practitioner involved in delivery or care of a substance exposed newborn needs to make an oral report to the local department, this is the Department of Child Welfare, no later than 24 hours after contact, and make a written report to the local department no later than 48 hours after this examination, treatment, or testing that prompted the report. So it's saying for substance exposed newborns, we are mandated as healthcare providers to report them to child welfare services. So, oops, why is this not letting me go to the next slide? The only time that you would not be required to report a substance exposed newborn is if you knew that the report was already made, or if you can verify at the time of delivery that the mother was using a controlled substance in the way that it was prescribed to her. All of these things have to be true. The mother was using it as prescribed. The newborn does not display effects of withdrawal from controlled substance that is determined by medical personnel. The newborn does not display fetal alcohol spectrum disorder, and it is not affected by substance use. So that is an incredibly broad, affected by substance use is a very broad term that is not defined anywhere in the law. So they're saying any substance exposed newborn that is not that it was exposed to a substance that was not prescribed to them needs to be reported. So that all seems like kind of cut and dry until you think about what do they mean by substance exposed newborns, right? Is this everybody that smoked a joint during their pregnancy ever? Is it everybody that drank a glass of wine? So they also go farther and define what a substance exposed newborn is. So a substance exposed newborn displays a positive toxicology test for controlled substance as evidenced by an appropriate test after birth. So this is a baby's test, a positive baby's toxicology test. It displays the effect of a controlled substance use or symptoms of withdrawal resulting from a prenatal controlled substance exposure as determined by medical personnel. So they are withdrawing. So they have a positive drug test, or they're withdrawing from a controlled substance, or they're determined to have fetal alcohol spectrum disorder. So the thing that I really want to make super clear to everybody, because I hear people misquote this all the time, the law gives guidance on who needs to be reported. It gives no guidance or mandates on who needs to be tested. There's absolutely no mandate to test pregnant people or their babies. And so the idea that a positive toxicology test requires reporting is if the baby has a positive toxicology test. So then that begs the question, why are we doing toxicology tests on babies at all? And so, think about the clinical implications of that if that's something that is useful. They don't say you have to send that test. So I also, when I give either this talk or this, have this conversation with people, oftentimes the response is, well, why do you care who gets reported to child welfare services? Aren't they there to try to help create a plan of safe care and help these families? And I'm not saying that they're not, and I'm not saying that no babies need to be reported, but we do need to be very careful about our policies and about how we go about doing these things. So why are there problems with reporting? Well, first of all, it sort of blurs the line for healthcare providers that we're asking you to tell us sensitive information, and then we are reporting you somewhere because of that. Now, whether that report is for your benefit or not, maybe we see that as totally for benefit. We're providing a plan of safe care. It's still can fracture that patient and provider relationship, that you told me something and now I'm going to tell it to somebody else. It causes further stigmatization of drug use. And so it equates drug use with child abuse, which is not a direct correlation. And it may prevent people from seeking care, which I'll give you some evidence of that in the coming slides. There's a racial bias due to subjectivity. You would think that a drug test is a drug test, right? So what can be the racial bias there? Well, there's a difference in who's reported and how those reports are handled based on the race of the pregnant person. So again, I'm not saying don't ever do testing. I'm not saying don't ever report anybody. I'm just saying we really need to think about what are we trying to benefit when we're doing these tests and creating these policies. So one thing that I like to, like a thought experiment that I like to do whenever I'm having a moment of concern or like this sort of cognitive dissonance, is remind myself that addiction is a medical problem, right? I am a physician. I'm taking care of this person for their medical needs. And so I substitute in another chronic medical condition for substance abuse and think to myself whether those two things, whether I would act the same way if it were a different medical condition. So I call it the diabetes rule. So you substitute in diabetes for substance use disorder in the same clinical scenario and see if you would have the same results. So for example, would you say the patient was non-compliant with her insulin regimen, which caused her to go into DKA? And because this can be harmful for her baby, and she made this choice, she needs to be reported to child welfare. She needs a plan of safe care. She made a choice that affected her baby. So now I am going to report her to child welfare. It doesn't really make as much sense, right? When you put in another chronic medical condition. And I know that these are not exactly the same, these two medical conditions, but I think that frequently we forget that we are healthcare providers and this is a medical problem. So just putting things into context, this is a graph showing the percent of children under the age of 1 with parental alcohol or drug abuse as the identified condition of removal in the United States. So this isn't necessarily saying that more babies are being removed. It's saying a higher percentage of the babies that are being removed because of prenatal alcohol or drug use or parental alcohol or drug use. So one could argue whether or not those are justified, but over half of the separation of child and parent is because of alcohol and drug use. And then this is showing the difference in those in race. So over the period of time of reports to child welfare, this is between 2010 and 2018, you can see that African American or the Black population has had an exponentially higher increase in the amount of reports to child welfare. And so again, there's a lot that goes into why that might be, but when you see such a huge difference in trajectories in different races or communities, you have to think, is there something that we're doing wrong here? Are we targeting a specific population with the way that our policies are making us act? So going back to what the potential harms of these policies could be, when you think about the idea that, potentially you're going to disclose this information to somebody else when your patient tells you, they know that this can happen, right? It's happened to them, it's happened to their family. And so it makes them afraid to disclose. And so in one study, 73, so almost 3/4 of the pregnant people reported that they were afraid of being identified as a substance user during their prenatal care. And their biggest fears were loss of custody of their baby, or they were afraid of criminal justice consequences, which again, I have a whole talk about that, but there are absolutely pregnant people who have been arrested and put in jail because of drug use and the laws saying that that is child abuse if they consume drugs while they're pregnant. The majority of the 26.7%, the people that were not afraid of being identified, the majority of them were using legal substances. So they weren't as afraid of being identified because they were using legal substances, alcohol and tobacco, which we also know are harmful during pregnancy, but for some reason that's less scary to be identified. So I like this newspaper article. It's this woman standing there smoking a cigarette and saying that she's really worried about the effect of all of the noise on her unborn child while she's smoking a cigarette. And so it's making this point that we value certain risks over others, and we maybe overemphasize some risks while we're ignoring other things that have the same or higher risk. Oops, sorry, go back one. So again, in that study, the quarter of people that were not afraid of being identified as drug users were using alcohol and tobacco. But tobacco is perhaps the most well-documented risks to a developing fetus, but we don't test for it and we don't report it. So we're reporting other substance exposed newborns, but not the ones with alcohol. Well, maybe alcohol if it gets to fetal alcohol spectrum disorder level, but not tobacco. So really then you have to think, are these policies concerned with the risk to the baby and the harm that's happening to the baby, or are they concerned with the illegality of the substance? And so we're not reporting pregnant women for driving in a car without a seatbelt. We're not reporting pregnant women for other potentially illegal activities that they're doing, but substance use, for some reason, that is one that we draw the line at. Other harms of policies, there was a study that surveyed, they did in-depth interviews with pregnant people who had addiction, and the most common strategy that they used to avoid detection was just complete avoidance of medical care. Over half of women said that they did not engage in medical care because they didn't want to be identified as substance users during pregnancy. Some reported that they switched to drugs that are detected for a shorter period of time. So for example, they switched from marijuana to alcohol because it's detected for a shorter period of time. And the other slide said because it's legal, and that nobody would recommend that you switch from marijuana to alcohol in pregnancy. They reported hiding their use from not only their doctors, but from their family, their friends, their partners, which then leads to social isolation and a higher rate of using alone. And we know that all of those things are related to a person's risk of fatal overdose. And so we are driving these people into the shadows and not encouraging them to come get care. They're not only are they not getting prenatal care, but they're using in much more risky ways. This comes from these in-depth interviews with these pregnant people. And one woman said, with my third child, I had no prenatal care because I was taking drugs. Well, not drugs, but I was down there smoking marijuana and drinking liquor. And they told me that if they see THC or something in my system, then protective services would get involved. So I didn't go. I didn't get no care, none. So again, if this policy is causing people to not get prenatal care, how is that helpful to our patients? So this is a study that looked at states that had mandated reporting laws. And this one is showing in states that had mandated reporting laws when the timing of initiation of prenatal care there, when people engaged in prenatal care. And there was a statistic difference that in states that had mandated reporting laws, people engaged in care later than in states that did not have mandated reporting laws and child abuse policies. In states that have mandated reporting laws, women were less likely to get adequate prenatal care. So they start later, they're less likely to have the full prenatal care that they need, and they're less likely to engage in postpartum care. Again, all of this is due to the fear. And so even if these policies are written and intended to be helpful and provide plans of safe care, they are having some unintended consequences, which is making people not engage in prenatal care. So I didn't put it all in here, but there is a whole body of literature that clearly shows that engaging in prenatal care improves outcomes, even if the person doesn't stop using drugs. So if they come to prenatal care, even if they continue using drugs, they still have better outcomes. And so if our policies are preventing people from engaging in care, then we really need to weigh that, the proposed benefits against the harms that we can see are happening. So other reasons that prosecuting pregnant people is a bad idea, and I'm not, again, I want to be clear, I don't want to directly equate child welfare reporting with prosecuting. Those things are different, but there are a lot of laws that I didn't have time to go over in here that are actually directly prosecuting pregnant people and equating substance use during pregnancy with child abuse, and there's legal consequences. So the problems are it overemphasizes drug use in pregnancy. It overemphasizes the risk of drug use in pregnancy because oftentimes things like arresting a woman is going to cause much bigger problems in her pregnancy than any sort of drug use that she had. It decreases the likelihood that she'll seek prenatal care. And there's no evidence that prosecution decreases drug use. And so we're just causing more problems without actually solving them. And again, I know that not everybody on the call is a medical provider, but just for medical providers, remember addiction, for everybody, remember addiction is a medical issue and we need to treat it like a medical issue and provide medical care. So I've told you all a whole bunch of problems. Hopefully in the second half of this, I will give you some pointers on places that we can hopefully improve some of this. If you haven't already been convinced to advocate for some improvement in our policies and execution of those policies. So again, for medical providers, this may sound a little bit condescending to say, like, think of the Hippocratic Oath, but I actually think that it frames it in a really good way. To again, just take a step back and think, like, what is our purpose here? What are we doing? How are we benefiting this person? And so beneficence, which is the idea that we should be doing good. So when you're thinking about that pillar, when you're taking care of a person, think, is this decision that I'm making, this test or this policy or this report, is this helping my patient? Is this causing medical benefit for my patient? Now that can sometimes get a little sticky if what would benefit mom and what would benefit baby are perhaps different things. But I think that we dichotomize that quite a bit. And we also think that it's one or the other, but frequently the policies and our actions are showing that we are really weighing baby above mom and not considering the literal person sitting in front of us and whether or not we're benefiting them. Non-maleficence is the idea of doing no harm, or non-maleficence. And so then the question I ask myself there is, does this decision have the possibility of harming my patient? So is it helping them? And is there a possibility it might actually hurt them? Then justice, thinking, would I feel this way or make this decision if this patient were not pregnant? So we treat people who are pregnant and use drugs. They have these like intersectional biases, right? And so we already kind of treat pregnant people like they don't have rights over their own bodies. And then also we treat substance users as a different class in society. Then when you put those two intersectional identities together, it can cause us to treat them in very different ways. And so thinking not just if it wasn't drug use, but if this person weren't pregnant, what would I do? And if this were a different chronic medical issue, instead of substance use, would I make the same decision? So again, the diabetes rule. And then in these sort of like parental and reporting laws and these policies, am I holding other parents or caregivers to the same standard? So maybe this person is using drugs. And so now all of a sudden we're making these judgments and referrals and things, but we're not doing drug testing of everybody else in their household or everybody else that they're exposed to. So it's really overemphasizing or it's disproportionately punitive towards the birth parent instead of, considering everyone. And then respect for patient's autonomy is the fourth pillar of the Hippocratic Oath. And so asking yourself, is this what the patient wants? And are they aware of all of their options? Did I really give them the options? Am I making this decision paternalistically and saying, I think this is what's best for you without talking to them about all of the possible options? So another area in addiction medicine that I sometimes see things going awry is in continuation of care. So a question that I get asked sometimes is, what do I do if a patient isn't compliant with their care or not taking their medication that I'm prescribing them, or they increase their use or continue use or return to use during pregnancy, right? So I run a practice that is for pregnant people with addiction. I'm prescribing them buprenorphine. She comes in and her test is positive for fentanyl. What do I do? Well, again, remind yourself that substance use is a chronic, relapsing disease characterized by compulsive drug seeking and use despite harmful consequences, as well as neurochemical and molecular changes in the brain. So that's a long way of saying this is a medical problem, and return to use, increasing use, drug-seeking behavior, these are all symptoms of a medical problem. We look at them as personality traits or behavioral things, but they are symptoms of a medical problem. It's the same as if my patient came into me and all of a sudden her sugars her glucose log was off the charts, right? You need to look at it as the same way. It is an exacerbation of their disease. So withholding care doesn't make any sense, right? Substance use is the only disease that I ever see somebody get worse and then their provider thinks I need to stop caring for them. I'm going to kick them out of my clinic. I'm going to stop prescribing their medication. I'm going to withhold care from them for some reason because they acted in a way that I didn't want them to. But really what they did was act in a way that is displaying to you that their disease is getting worse and they actually need more care. So again, with our diabetes example, if a woman comes in DKA, you don't say, you didn't take your insulin, I'm kicking you out of my clinic. I'm not giving you more insulin. No, of course, you evaluate the situation from a medical perspective. So we need to do the same thing for substance use. In motivational interviewing with patients, I think it's really my favorite phrase that I've ever heard about motivational interviewing is that it's supposed to be a dance. You're supposed to be dancing with the patient, not wrestling with them. So you're not forcing them to a conclusion. You need to assess and respect their goals and understand that ambivalence is common and recovery is really not a linear process. One of my patients told me once, and I really like this analogy, that she had been in recovery and she hadn't used for 90 days and she was all proud of herself. She got her 90-day chip, and then on like day 96 or something, she used and she was feeling really bad about it. So we were talking about it and she was like, if I was training for a marathon and I ran every single day and then I skipped a day running, that doesn't negate the fact that I ran for 96 days in a row. Like I still have all of that strength. And it's the same mental strength, right, that you've built up over that period of recovery, and understanding that this process ebbs and flows, and just because somebody is using now doesn't mean that they're using the same way that they were before or the same way that they will in the future. Another thing that people often tell me is, well, I'm afraid to prescribe these medications because I'm just becoming a legal drug dealer, right? I hate this phrase, but people say it all the time. I'm just becoming their legal drug dealer. I don't want to do that. But we really need to, again, frame this reference, our frame of reference of like, what are we trying to do? A medical benefit. So we should always be thinking about harm reduction. We shouldn't only accept people into care if they completely stop using drugs. Again, it's not a linear process. If I told you that you were obese and you needed to lose 30 pounds and you came back a week later and hadn't lost 30 pounds, I wouldn't kick you out of my practice, right? It's a process. It took you a while to get there. It's going to take you a while to get to your end goal. And recognizing that not everybody's goal is to completely stop using, and helping them in that journey, because if they are unable or unwilling to stop using and you cut them off, then they're going to use in very unsafe ways. And so harm reduction looks like things like needle exchange and fentanyl test strips, so they understand what drugs they're using, naloxone education that we're going to talk about in a minute, educating people not to use, if they're using injection drugs or opioids, not to use alone, so that there's somebody with them if they use something that they didn't mean to use, to understand where their supply is coming from and try to get, have some harm reduction in supply, or switch from injection to snorting, because we know that has a slightly lower risk of communicable diseases. And so people get very uncomfortable talking about these things sometimes, and they feel like they're promoting their patients using drugs. But in the same way that when we ask about suicidal ideation, it doesn't increase people's likelihood of thinking that they should go commit suicide. Talking about these things actually helps people to come up with ways of harm reduction during their journey. And then just remember that buprenorphine specifically is a partial opioid agonist. And so if I'm prescribing somebody buprenorphine and they're taking it, but then they also take fentanyl, that's actually safer than when they were just taking fentanyl on its own. So am I happy that your drug test shows fentanyl, or that you told me that you're still taking fentanyl? No, of course I would prefer that you didn't, but this is still a safer way to use than when you were using just fentanyl on its own, because buprenorphine has some, because it's only a 50% opioid receptor agonist, it's less likely to allow overdose. So harm reduction is not new or unique to substance use, but for some reason we have a harder time talking about it with substance use. So some other examples that are very well accepted in society: sunscreen. We know that the sun causes skin cancer, right? We don't tell people don't go outside. You cannot take that risk at all. No, we talk to them about ways to decrease that risk, right? Sunscreen. We don't tell you not to drive a car because you might get in a fatal accident. You wear a seatbelt. Speed limits, birth control, cigarette filters. All of these things are ways that we're trying to improve people's health and the outcome in case something bad happens, right? But for some reason in substance use, we view it as so binary, of like all or nothing. You have to stop right now, as opposed to thinking about ways that we can make it safer. I think this slide, I don't know if this slide is really in the right place, but I want to make the point that I think another thing that we really forget about when we're taking care of pregnant people is that we focus a lot on the pregnancy, and that can be great because it is a motivator for some people. Going back to motivational interviewing, a lot of times people will tell you, I want to be healthy for my baby. I want this, pregnancy to turn out well. That's great. But if you're only focusing on the pregnancy, then what happens when they're postpartum? Now they subconsciously, without straight up saying it, you gave them the message, you're important and your care is important because you are gestating a baby, right? Now that baby's outside of you, now that all of those reasons that we just talked about for the last 9 months of you not using drugs have gone out the window. we withdraw a lot of support immediately after somebody's not pregnant anymore, because again, this implicit bias in society of like, pregnancy is important, but then we don't have to continue to provide care afterwards. So anyway, this is showing the rates of abstinence of illicit drugs, cigarettes and alcohol in different trimesters of pregnancy. So we actually get, especially with illicit drugs, we get to a pretty high percentage of people being abstinent in the third trimester. But then after pregnancy, those abstinence rates drop immediately. And so making sure that we're continuing to care for the person even when they're not pregnant anymore is important. So laws about prescribing have changed a little bit recently and actually loosened up a bit. Buprenorphine prescribing laws, they're probably most people are familiar. There used to be something called an X waiver that you had to apply for if you were going to prescribe buprenorphine, and you had to have an DEA number that had an X on it, and only certain people could prescribe it, which of course was always absurd because anybody can prescribe OxyContin, oxycodone, all the drugs that got us into this mess, but you couldn't prescribe the treatment for them. So, eventually we came around and realized that that was kind of absurd. So Congress abolished the X waiver rule in December of 2022, and then Maryland in February of 2023. And so anybody that has a DEA number now can prescribe buprenorphine. There are no limits on how many people you can be treating. And this was to improve access. The Ryan-Haight Act happened in 2008, and it was related to controlled substances. And that said that you could only prescribe to people after an in-person evaluation. You couldn't give them buprenorphine just talking to them on the phone, right? But then, of course, COVID happened and we couldn't see people in person anymore. And so the first temporary rule exception was passed in March of 2020 in Maryland. And it said that you can prescribe to people after a telehealth visit. You don't have to do a physical evaluation of them. This was, again, to try to increase access. The second temporary rule, which was just an extenuation of the first temporary rule, has now been extended until December of this year, December of 2024. And they're working on legislation now to make this a permanent law that you can prescribe buprenorphine after just a telemedicine visit. And this helps with access to care in a million different ways, but a big way is helping people that are not near centers that are near cities that have a lot more prescribers in them. Easy Access and Treatment for Opioid Addiction Act was passed in August of 2023. And this is about methadone. So, methadone is not something that we can prescribe. It can only be dispensed from specific sites that are blessed by the government. And the Easy Medication Act and Treatment, Easy Medication Access and Treatment Opioid Addiction Act allows for dispensing of 3 days of methadone for opioid use treatment. Now, I will be honest, I am not an expert in this act. I have not yet had success in getting this actually dispensed to patients of mine, but I bring it up because the point is the tides are changing, and that we're trying to make it more accessible for people to get medication for opioid use disorder. Another common myth or thing that I hear from people is that, again, in this sort of like drug dealer vein of like, but my medical license is at risk. I'm prescribing opioids to this person, and I could lose my medical license if, who knows, XYZ, whatever thing they might be afraid of. So I wanted to point out, I spent a long time looking through all of the providers in Maryland that have lost their license in the past 5 years. This is all public knowledge. This is all public data. You could look through it. It's very fascinating. But I want to make the point that it is possible to have your license suspended or revoked, or your prescribing privileges revoked too, either your license revoked or your prescribing privileges. But this only happens in very, very egregious cases. If you read the cases of when this has happened, it's pretty obvious that most of them were purposeful. So it happens if you're prescribing very high doses of opioids for pain without having any sort of proper evaluation of, have they had any other treatment? Do they have pain? Are my opioids improving their pain? And basically just continuing to prescribe high doses without any sort of evaluation. Prescribing opioids without an established provider-patient relationship. So again, as we talked about, this established relationship can now be via telehealth, but you can't just you can't just write a prescription for your friend that is not your patient. Improper documentation of reason for prescribing medication and or dosing. So, as long as you have good practices about why you're prescribing medication, the person has opioid use disorder, I'm prescribing this medication, I'm going to increase their dose because they were having withdrawal symptoms or cravings, just making sure, this is good clinical practice anyway. And then issues of moral turpitude, which were basically just very, very egregious things that you're clearly acting outside of the standard of care. So it's very uncommon. So now we're going to get into family education. This is a little bit of a left turn, but it's all, sort of in the same vein of how do we keep people safe. So we know that for opioid use, particularly, that the thing that helps save lives and decreases overdose and improves care the most is medication for opioid use disorder. And there's a lot of stigma around that, particularly in pregnancy. And so I put these two slides in every talk that I have to just kind of remind people about what MOUD is. So when somebody is using opioids chronically, they start by getting this euphoria when they're using. And then over time, if you've ever talk to a person that has opioid use disorder, you find out that over time, they're actually using more to keep themselves out of withdrawal than they are to get to that euphoric state. So that's when it becomes addiction, right? That it's not so much that they're looking for euphoria, but that their body's physically dependent on it. And so now they need it to feel normal. So the purpose of medication for opioid use disorder is to keep them in the asymptomatic range. So there's this very common misperception that you're amongst patients, amongst their family, that you're substituting one thing for another. And like, I don't want to be addicted to another thing, but it's not addiction anymore. It's a physical dependence on that medication, but addiction are these behaviors that are related to your drug use, right? So like continuing drug use despite health consequences or other consequences, and spending a lot of exorbitant amount of your time seeking out drugs, and those things all go away whenever you use medication for opioid use disorder. And so we're just stabilizing people to help them feel back to normal. So if you use the diabetes example, it's just giving them their long-acting Lantus because their pancreas isn't working, you're getting them back to baseline. So that is important education, not just for our patients, but for their families. Because most of the time when people don't want to take medication, if you talk to them about why, there's a lot of external pressures and people are judging them and people are, telling them that's bad and they're still an addict and they're not clean unless they stop using all medications. So it's important for education. So again, addiction is a brain disease. Dependence and addiction are very different things. You can be physically dependent on a lot of medications, just like you are in MOUD, but it doesn't mean that it's not the same thing as addiction. So again, likening it back to other chronic medical conditions. So one of the frequent things that I hear from family members and support people is that it's just so frustrating because again, it's not this linear recovery is not linear, and you don't just like keep getting better and better and better. There are times where you're going to return to use or you're going to stop using your medication, and that is the natural process of this disease, right? But if you liken it to other chronic medical conditions, the rate of relapse or worsening of the condition is actually very similar, right? So people with diabetes over time need more insulin. People with hypertension over time, their blood pressure gets worse. They need more medication. Same thing with asthma. You wouldn't judge somebody for being admitted for an asthma exacerbation the way that we do people with addiction. And so it's a chronic medical condition just like any other one. Postpartum MOUD, so we recommend continuation of medications for a year postpartum. And again, there's a lot of pushback from family members about that. Like maybe you convince them that they should take it during pregnancy, but now I'm done. Like, why do I need to keep taking it? So really, if somebody wants to stop taking their medication or is unengaging in care, trying to figure out like what are your external pressures that are causing that to happen versus like what are your internal personal goals. So now taking just a couple of minutes to talk about overdose prevention. So I think this slide is like so jarring. This is from the state of Maryland, from the Maternal Mortality Review Committee, that shows that unintentional overdose and substance use are by far the leading cause of death, pregnancy associated or related deaths. And so during pregnancy and the year postpartum, by an order of magnitude, overdose is the most common reason for death. And so what is opioid overdose? I think it's confusing sometimes because an opioid overdose, not all are fatal. And so we don't really track very well how many overdoses there are because a ton of them are not reported. Opioid overdose means that a person has pinpoint pupils, they're unconscious, very difficult to arouse, they're having difficulty breathing, their breathing rate is slowing. This is oftentimes, if we identify this, it can be reversible. So remembering, not even without treatment, not all overdoses are fatal. So we don't really know how often it happens. We do know in pregnancy that the time that people are the very most likely to overdose is in the year postpartum. It's not during pregnancy, because again, we're very focused on the person during pregnancy. But in the year postpartum, they are much higher, much higher rate of overdose. And that overdose, the risk of overdose dramatically decreases in people that are on MOUD. So knowing that MOUD is actually the only factor that's related to decreasing the risk of overdose. Naloxone, or Narcan, is an antagonist, a receptor antagonist. And so it reverses overdose because it kicks all the opioid receptors off of the blockers kicks all the opioids off of the receptors and blocks the opioid receptor in the brain. And so that person doesn't have that agonist effect of the opioid anymore. Opioid overdoses, people die because it causes respiratory depression and they essentially just stop breathing. And so when you give somebody naloxone, because it removes all of the opioids from the receptors, then they can start breathing again. Naloxone education and distribution has been shown to decrease overdose deaths in communities. So in communities where there's education and access to naloxone, they show over time that there's a decrease in overdose deaths. So how do you get naloxone? There are multiple options for this. So providers can write prescriptions, insurances cover it. Even without a prescription, there is a standing order in Maryland that you can walk into any pharmacy and ask for naloxone and they give it to you. It is a prescribed medication, but I forget what they're called, the person in charge of all the medical stuff in the state writes a standing order that says, I'm prescribing it to everyone. Anybody can have naloxone. So anybody should be able to get it from a pharmacy. And then there are also distribution options for those of you who are in medical practices or care for this community. You can become an organization that dispenses naloxone for free. And so if you contact the Maryland Overdose Response Program at this email address, or you can Google it, they can teach you how to become a program that is dispensing naloxone to your clients or patients. And then if you or your organization need training in naloxone and how to use naloxone, when to use it, the Naloxone Project is a group that goes out and trains places that trains medical practices and other places about how and when to administer naloxone. And then the Moms Initiative is a part, there's so many things called Moms, so I just want to be clear, this Moms Initiative is part of the Naloxone Project, and their goal is to get naloxone to be given to everybody, anybody that needs it, on every labor and delivery, so that when people are leaving after having a baby or after a triage visit, they can just be handed naloxone. And so if you contact the Naloxone Project, they can tell you how to get involved in the Moms Initiative. All right. There's, as usual, I talked for quite a long time. I'm sure there are some questions. I'm happy to also stay past the exactly 1 o'clock mark if there are more questions. Thank you all for your time today.
Thank you so much, Dr. Mark. Such great information. There is a question in the chat. Please let me know if you'd prefer to follow up with this person one-on-one as a clinical call. But this person writes, I'm a home visiting nurse during a client's pregnancy and also follow up with them for up to 1 year post-delivery. I have two problems. One, my clients seem hesitant to share with me that they use substances. And two, the clients who do share this information with me will accept care to a program, but then don't show up to their scheduled intake appointment. Mm-hmm. Are there methods I could use to help improve these issues?
Sure. So, I mean, it's a complex question with a very complex answer. So I think everybody working on themselves, building trust in yourself as their provider, but then trying to build trust in the system, being very clear with people about what you do and do not have to report, or how you will respond when they give you this information. So in my first prenatal visit, when I ask people about their drug use, before I even ask, I tell them, just like when we talk about suicidality, there are everything you tell me in this room is private with a few exceptions. And then I tell them if there are exceptions of times that I would have to break their confidentiality, and being very clear about that and not ignoring the fact that there are either times that we have to report or times in the medical system in general, people have to be reported when they disclose, I think is really helpful, because in general, people don't understand when somebody needs to report and when they don't. They just know that their friend lost custody of their baby and she did drugs, and they don't know the whole story of what happened behind that. And so there is this like incredible fracture in our system between patients and the healthcare system, and they just don't trust us. And that can't be fixed overnight, but we need to work on it. And I think so first is just being disclosing that when you do and do not, and telling them what you're going to do with the information that you're asking, why you're asking it, why do you need to know this information? Because otherwise it just sounds like you're nosy or judging them. And then with the people not showing up to intake, this is a very common problem. And I think oftentimes, I'm not saying you do this, but oftentimes this is viewed as like, they don't care, they're not engaged, they, if they really cared, they'd show up. But trying to find out what the barriers were to that person coming to their intake visit, right? Was it a childcare problem? Were they going to get fired from their job if they left that day to go to their intake? Do they have a controlling partner that wouldn't let them leave because they don't want them to go to care? There's a million different reasons. So just following up with them to find out what barriers they had to making it to that visit. And that's true for all types of medical care.
Thank you. It doesn't look like there are any other questions, but usually after one, a few more trickle in. So we'll sit and wait for that. But while we do wait, I just want to reiterate, I will follow up with next steps to claim credit. You will have access to the slides both via email and via the portal. But thank you so much for joining today. Please feel free to log off if you have to. If you do have questions, we can stick around for a couple more minutes. And once again, this will be recorded, and the recording will be on our website within 1 business week. We're just getting a bunch of thank yous, so we can wrap it up. Once again, cannot thank you enough, Dr. Mark. This is a highly requested topic, and you really gave some action items for providers to take to their own practices. Thanks for joining us today.
Thanks. Thank you, everyone, for paying attention to this topic.